Hello, my name is Arnulfo Garza. I'm a fourth year medical student at Texas Tech El Paso, and today I'm going to be presenting on giant cell arteritis. So the history of GCA. GCA started or was first seen in 1890 by a British surgeon called Dr. Hutchinson. He had a patient that was having trouble seeing using his head because he was having some pain, and then Dr. Hutchinson found some red streaks on his head. He named it the arteritis of the aged. Then in 1932, Dr. Horton described some scalp tenderness on the distribution of the temporal artery, and he named it Horton's arteritis, and that's today known as another name for GCA and temporal arteritis. Now, GCA is the most common vascularity, uh, and is usually seen in the distribution of the cranial and extracranial carotid artery. It's usually seen in patients over 50 years old. It's usually seen in females over males. It's more common in females, also more common in white people, but it's usually seen, and it can be seen in every single ethnicity. So keep that in mind. Now, the clinical presentation. These are the symptoms that should raise some flags for you. A patient that is over 50 years old that has a headache, that had some visual disturbances, a jaw claudication, which is ischemia to the jaw. Just like you got ischemia of the leg, you can get ischemia of the jaw. So that's jaw claudication, which is a very specific symptom for this disease. Constitutional symptoms and signs, and an elevated ESR and CRP. Now, the presentation for this disease is very variable. So you need to maintain a high index of clinical suspicion. And here I have a picture of Spider-Man. Now, Spider-Man has, when he's faced with danger, he has something that warns him, this peculiar sensation known as spider sense. He gets this tingling sensation in his back, and he knows that danger is coming. So I'm putting it here because some of these symptoms should trigger some of that with you. You should see the symptoms and be worried the danger might be present, and use this at your advantage to protect your patient's vision and hopefully identify those patients that do have this disease. Now, the ACR criteria in 1990 was created. You see here some of the symptoms we already talked about. And here they saw that specificity and sensitivity of this is over 90 in both sides. It's very important to keep in mind these symptoms. Now, moving on, they create Dr. El Diary et al. They created this diagnostic algorithm for patients with suspected GCA. Now, I'm going to mainly focus on one part of this, which is number one, which is evidence of anterior extracranial circulation ischemia. Now, we're going to start with AION, which is anterior ischemic optic neuritis. Now, whenever you have a patient with AION, you're going to see that they have a rapid onset of unilateral vision loss. You're going to present with 200. In a visual field defect, it can be like an altitudinal defect, which is the most common one. And whenever you do an exam, you're going to see something similar like the picture I have here. This picture, it's very classic. It's going to be a chalky white pallor of the optic nerve, and there's going to be some edema. So you can see that clearly here. Now, another presentation that they warned here about is PION, which is posterior ischemic optic neuritis. This ischemia is present posteriorly in the retrobulbar portion of the optic nerve. So you might not see some ocular abnormalities on examination at the beginning, but in 6 to 8 weeks, some of these things are going to start being available. Available for you to see, and the optic nerve might be more atrophied. You're going to see some optic rim pallor. There's going to be some disc edema later on as the atrophy is developing. And RAPD might be present as well. So these are things to keep in mind because you might not see something at the beginning. Now, CRAO, it's also an ophthalmic emergency. We know that one of the true ophthalmic emergencies that requires immediate intervention. A classic finding here in this picture is a retinal widening with a cherry red spot. This retinal widening is caused by the opacification of the nerve fiber because there's edema there, because there's ischemia happening at that level. Okay. Now, moving on, we also have the cilioretinal artery occlusion right here. Now, this picture, great pictures, we can see that there's some perfusion problems at the distribution of the cilioretinal artery, and telling us that it's occluded. It's right superior to the fovea, so we can see it right there. Now, what do we do whenever we're worried about someone having this? We do a TAB, a temporal artery biopsy. It's the gold standard. You usually want to get at least 2 centimeters of the temporal artery being removed. This is, you can see in this picture, the way it's excised. It's the most accessible artery that we have access to. Like I said, consider gold standard. Its sensitivity, finding its sensitivity, it's always been hard because we don't have a definitive diagnostic tool. They can tell us if a patient has GCA. So the sensitivity that we can find in the literature is ranging. Some of the ones I found are like 87, like the one I'm quoting in this slide. But one of the big takeaways of this presentation is that if you get a negative biopsy, that does not rule out GCA as a diagnosis. That's really important. Now, the structure of an artery wall is here. You can see, I want you to pay attention to a couple spots in this. You probably remember some of this, but the tunica media is usually when you're gonna see some markers of inflammation, and the internal elastic membrane. The internal elastic lamina, also known as internal elastic membrane, is a part where you wanna look for here in GCA. And you can see a slide here. Now, moving on to the common histopathological findings. If you see here in the picture A on the left side of your screen, you can see that on the tunica media, there's some Panarteritis, but specifically there's a collection of CD4 cells and macrophages. So you can know there's some inflammatory markers there. And on the right side, you see one of the pathognomonic findings of GCA, which is the giant cell. The giant cell is pathognomonic. You're gonna see a lot of pathologists just seeing this and knowing it's GCA is what you're looking for. That's what you wanna see. But the other big takeaway of this presentation is that even if you don't have a giant cell, there's still other things that can tell you the patient has GCA. A lot of pathologists in the node will tell you that there was no giant cell, and so maybe GCA should not be that high in your differential, but there's other things that you can see. In this picture, this is an artery that has some irregular intimal hyperplasia. As you can see, there's no acute inflammation or there's no giant cells available for us to see here. So some people might think there's no GCA, but there's other things you can look at that might tell you, oh, this could be GCA. You need to pay attention to those. The three things we have here is the elastic lamina breaking, the macrophages attacking the elastic lamina, and the elastic lamina duplication. So if we move to the next picture, we can see that right here. On the top of your screen, on the red circle, you can see that the elastic lamina is compromised. There's a break right there. That should hint you like this can be GCA. The bottom side, you have the elastic lamina being duplicated. This is another thing that should tell you, hey, this might be GCA. Now for this kind of preparation, we're doing an elastic stain. We're using what is known as MOBAD. It's a pentachrome stain, and it's gonna highlight elastin black. And that's what you see here. That's how you can actually know how the internal elastic lamina is if it's compromised or not. Now this next slide, you can see here what we know as CD68, which is a marker for macrophages and other inflammatory markers like monocytes. So here we know that they're actually located at the elastic lamina, telling us they're actually attacking the elastic lamina. This is telling us that although no giant cell is seen, there's actually active disease present at the level of the arteries. So it's very important to communicate to the pathologists that even though there's no giant cells, they can still do a couple of these stains to find if there's a present disease. Now, there was a study talking about a little bit more about CD68. There was a study done looking at some markers, specifically CD68, and seeing how it related to GCA. So as we have right here, it's a glycoprotein found in monocytes and macrophages, and it's telling us, or it helps identify cells from the monocyte lineage. And in this study, they found that those patients that had greater numbers of CD68 cells in their histology were more likely to require additional immunomodulatory therapy. And here are the results, just summarizing them a little bit. Caucasian people were more likely to have CD68 positive cells. Patients that had transient visual obscurations like amaurosis fugax had more CD68 positive cells. CD68 positive cells per slice predicted the placement of immunomodulatory therapy and the referral to rheumatology. So this is a very helpful thing to look at. And here's some more results with the symptoms that are common, and amaurosis fugax was one of the most significant ones. Now, outside of the tab, another thing you can do is the color Doppler ultrasound. A color Doppler ultrasound is more sensitive. It allows you to visualize more than just the external temporal artery. And this disease is not only present there, but it can be present somewhere else. So this can help you. So consider doing this if you have a negative tab, but you still have a high suspicion for GCA. There's other prognostic markers that can help you. I listed some of them here. Persistence of histiocytes after you've been treated with steroids for a couple of weeks tells you that they might be healing. And the number of relapses can also tell you how bad the disease is. Visual acuity and presence of progressive visual loss might hint you at the prognosis of the disease in a patient. Now, therapy, glucocorticoids are the mainstay of therapy. A lot of the times they're long-term. Patients are on them for several months and years. There's no consensus, but Some of the things I was able to find is that when patients have visual symptoms, you want to do IV methylprednisolone is preferred. And when they don't have symptoms, you might get away with doing oral glucocorticoids. You want to protect the fellow eye. It's really important, even if it's only unilateral. And there's other therapies, other immunosuppressors like methotrexate and azathioprine that you can use, but glucocorticoids are one of the main ones. The other thing you can consider is using tocilizumab, which is an IL-6 receptor blocker. IL-6 has been demonstrated to be elevated in patients with arteries affected by GCA. So someone really creative found a way to block this receptor, and this inhibits the IL-6 differentiation from naive TH cells to TH17 cells. So the level of disease activity in GCA is really well correlated with the IL-6. So by blocking it like this, you're able to get a good response. Now, as a summary, I'm going back to the spider sense. The spider sense is that tingling sensation that whenever you hear a symptom of a patient that is over 50-year-old, you should be getting this tingling sensation in your back and saying, oh, this might be GCA. Let me investigate a little further. It's really important. Consider the diagnostic criteria, some of the symptoms that we talked about. Now, number 3, if high suspicion for GCA, you want to give steroids before you TAP. You always give steroids before you even consider doing a temporal artery biopsy. And if you have a negative or there's no acute inflammation in the slide, consider asking for a CD68 and elastic lamina stain, like we talked about. And number 4, I'm putting it again, you want to do a TAB after steroids. So steroids before the TAB. And if you have a negative TAB, consider doing a bilateral one or doing a color Doppler ultrasound. Number 5, I think it goes without saying, you want to coordinate the care of rheumatology and internal medicine to make sure that the patient that might be on long-term corticosteroids is well managed, because the side effects are always present. I want to thank you so much for listening. I want to thank you to Dr. Prospero Ponce for helping me in the making of this presentation and guiding me. And here are my references, and feel free to email me with any question. Thank you so much.